Okay, welcome in everyone. Good evening. It's officially 5 o'clock Central Time, so we're going to go ahead and get started on the webinar so we can get you guys going and learning. Today we're going to be using the webinar chat feature in the Q&A section in Zoom. So if you have any questions, I'm here on chat support today, and we also have Jennifer here. Bear with us because we're not robots. So if you guys have questions regarding the webinar or about nursing school specifically for Archer, we're happy to answer them. So you can go ahead and put those in the chat or in the Q&A and we'll get you guys as soon as possible. But just before I turn the time over to Rebecca, I want to let you guys know about Archer for Nursing School. You may already have heard about this a million times at this point. It is our new product. It's been out for a couple of months now, and it has been what we have been working on. Me, Jennifer, Rebecca, we're all instructors for Archer for Nursing School. Been working on it for quite a while now, almost 2 full years, to really get you guys a comprehensive package for nursing school. I think we all went through nursing school, and I just remember being in your guys' shoes and knowing how hard it is. I just remember thinking, oh my goodness, it's so much information. It's like a fire hose. Like, it's just all of a sudden you are learning so much at such a quick speed. And I found that really overwhelming. And I thought to myself, what can we do for nursing students to kind of take the burden off a little bit and make nursing school a little bit more fun, a little bit easier, so that when you get to the point that you're, like Maria said here, about to take the NCLEX and pass our exams, that you feel ready, that you're like, you know what, I know this information, I'm ready to be a nurse. So with that, we've made 20 full courses for you guys. So everything you're going to take in nursing school, we have a course for, and then we even have some extras that I like to call our transition to practice courses. Those just focus a little bit more on the things that, like, once you take the NCLEX or when you're in clinicals, that stuff that is hard. Like, we have an entire course on ABGs. That was a subject I really struggled with. So now you have a whole course you can take from Archer on ABGs, how to interpret them, what they mean. There's a whole course on calculating doses. Another thing, I'm not great at math, so I was like, I may want to make sure we have a specific course for that. Jennifer teaches our maternal and reproductive course. Rebecca, of course, teaches our ICU and adult health course. So, you get these people that are really good at what they do. I'm not great at pediatrics, but I love geriatrics. So I, of course, teach your geriatrics course. And you get to learn from us in a way that is really fast. There's over 1,000 what we call on-demand lectures. They're pre-recorded. They're really short. So rather than sitting through, 3 full hours on heart failure, if you're just struggling with, heart failure medications, watch the one little clip on that. If you're struggling with, pediatric milestones, watch the one little clip on that. And then to supplement, after you've watched those lectures, we have over 5,000 practice questions. And that's in addition to the NCLEX questions that are already out. So you can go ahead and get, 5,000 additional questions that you can practice before you take your exams in nursing school, before you take the NCLEX, that are really going to drive home those topics you're learning. And then lastly, my favorite part of Archer for Nursing School is our cheat sheets. There are these one-page documents that we have had like professionally illustrated. So they're really colorful. They've got tables. They've got mnemonics. I'm a visual learner, so I wanted these. In fact, I have graduated from grad school already, and I have them printed out. I have, them laminated, and I look at them that way because they're really great references for those hard to know topics. So if you struggle with ICU, Rebecca's going to cover these shock states today. But if you want more information on shock states, you want other courses for nursing school, all of these 20 courses are entirely free through January 1st. So you want to sign up as soon as possible. Our goal was, of course, to make it as affordable as possible. We remember being nursing students that struggled and lived off top ramen. So we really did try to make it affordable. And with that, through the end of December, we have made all of these courses free. You can sign up here with this QR code in the bottom left corner, but you can also just go to archerreview.com, click on nursing school, and sign up there for all the courses that you want. I really think you guys are going to love it. So without further ado, I will turn the time over to Rebecca now so she can talk to you guys about shock states. I'll just be here in the chat if you guys need me.
Oh, can you see me? There we go. Thanks, Annie. Okay, let me just get my screen set up here. Perfect. Hi, everyone. So glad that you're here and so glad we've got so many people looking to talk and learn about some critical care concepts. I'm going to bring us back to our title slide here because there's kind of a lot going on. And I want to briefly talk about each of these concepts that we're going to go over. This is definitely a little ICU crash course today. When we're talking about shock states, Sepsis, septic shock, getting into MODS, which stands for multi-organ dysfunction syndrome. These are all conditions that we are going to care for in the ICU. You might see sepsis on other units, but as soon as it turns to septic shock, we want that patient in the ICU. So I am going to start with SIRS and how SIRS is different than sepsis and how sepsis is different than septic shock. Then we'll transition into that multi-organ dysfunction syndrome. Sepsis is a huge cause of it. And then we'll close out talking about all of our other shock states. Sepsis and septic shock are probably the ones that we see the most in the ICU. So I want to spend a large chunk of time there and help differentiate some of these terms that you might hear when you're at clinical. If you get a new grad job in the ICU, you'll hear these terms all the time, and just bring some clarity to these a bit more complicated subjects. Okay, so let's get started here, differentiating SIRS, sepsis, and septic shock. So SIRS, if you've never heard this term before, it stands for Systemic Inflammatory Response Syndrome. So what we're seeing is systemic inflammation. When you see that term systemic, I want you to think total body. We know that the inflammatory response takes place in response to injury. Usually we think about it at a localized area. So if somebody burns their hand on a stove, we think about inflammation responding to that burn at the site, at the location that that injury took place, which would be the hand in that example. Well, um, what's going on with SIRS is instead of just localized inflammation, we're seeing total body inflammation. And when we say we have total body inflammation and there's not necessarily an infectious source, that means we just have systemic inflammation. We don't necessarily have an infection, but our body's reacting to something. And a good example of this that I saw in my practice all the time when I worked on a post-cardiac surgery unit was after patients come out from open heart surgery, and they got their coronary arteries fixed or a valve fixed. Maybe they had a mitral valve replacement, something like that. During that surgery, they had to be put on what's called a cardiopulmonary bypass machine, which is basically a big machine that takes all the blood out of their body, puts it through a pump and an oxygenator, and takes over the job of the heart and the lungs so that the surgeon can operate on the heart, and the heart's not responsible for pumping blood out to the whole body. And then it sends it through that pump, that filter, that oxygenator, and sends it back into the body. That means every single blood cell just came in contact with a foreign object. So that is going to kick off an inflammatory response. Even though those cells might not be infected with anything, they're just kind of annoyed. And that annoyance will lead to an inflammatory response. So that's how we can get SIRS without necessarily sepsis. Now, the criteria for SIRS is listed here. We can see either hyperthermia or hypothermia, so temperature over 38 degrees Celsius or under 36, a heart rate that's greater than 90, showing some sort of distress. The body's trying to compensate for this inflammation. Same with our respiratory rate being elevated above 20. We're trying to get more oxygen to these tissues that are injured. And then white blood cells over 12,000 or under 4,000. We don't always need an infectious source to see a rise in white blood cells. Now, the key here is we only need 2 of these to say our patient is in SIRS. They're experiencing inflammation everywhere. It's hit their bloodstream. Now, sepsis is the exact same criteria, except now we have an infectious source. My example for this is when you have maybe a skin infection like necrotizing fasciitis. Well, that gets deeper and deeper into the skin and it starts to come in contact with the bloodstream. And now that infection is no longer localized to one specific area, it's all in your blood. And now every single cell wants to have this inflammatory response. Now, there's 2 things with an inflammatory response that I want you to remember that happen. We know that the inflammatory response of our body is a huge cascade of events, but there's 2 characteristics that occur with inflammation that help make everything else that happens with sepsis make sense. And that is vasodilation and increased capillary permeability. Let's break down those concepts for just a second. With vasodilation, when we have inflammation, a site of injury, we want to bring more help to that area. We're going to do that through vasodilation. That will allow more blood flow to that area of injury and get those white blood cells in there, get cytokines, all of our mediators at the site of injury to help restore the tissue, help heal. Now, we also need to increase capillary permeability to allow those same helpers to get into the tissues. So we we're going to see vasodilation and increased capillary permeability. When that's happening on a systemic level, we are concerned then for septic shock. We can quickly transition from having a massive inflammatory response to now having a reduced blood pressure and hypoperfusion caused by that sepsis. We can also see hypotension in SIRS as we have this massive vasodilation occurring. So that's kind of how we can transition from SIRS to sepsis to septic shock. SIRS can get us to a shock state as well. And with that vasodilation, we can have something called relative hypovolemia. So when we have that massive vasodilation, we might have the same amount of blood volume that we did before the vasodilation, but now our blood vessels are so much bigger that they're relatively hypovolemic. They're vasodilated. So we will see hypotension and hypoperfusion even just from a SIRS response. Okay. Digging a little bit deeper, let's talk about this pathophysiology of sepsis. So like I said, with sepsis, we have to have an infectious trigger. That's what differentiates it from SIRS. And it's interacting with the blood, and that's what's going to cause that systemic inflammatory response. We talked about how we get massive vasodilation from this initial inflammatory response. We see this endothelial dysfunction. That's going to increase our permeability. And there's a specific mediator that's released called nitric oxide. That is a potent vasodilator. If that's being released everywhere, now we've got potent vasodilation all over. That's going to drop our blood pressure. A huge part of sepsis and a risk of sepsis is DIC, which is a coagulopathy, and it stands for disseminated intravascular coagulation. And when you hear DIC, I want you to think clotting and bleeding occurring at the same time. There's another term that we use for DIC that I really like. I think it's pretty helpful to remember how DIC works, and that is a consumptive coagulopathy. That's the other name for it. And the reason that that makes sense is because with total systemic inflammation, we're going to see this endothelial damage that's going to initiate our clotting cascade. That's what initiates our clotting cascade when we're functioning normal. Now, the problem is that mediators, we have so many inflammatory mediators being released that fibrinolysis is suppressed. So we are not going to be breaking down any clots that we're forming. So we're going to have massive clotting occurring. With that massive clotting, we are going to use up platelets. We're going to use up our clotting factors. We are using up all of our abilities, our proteins that help us clot blood, because we're initiating the clotting cascade over and over again, and we're not suppressing fibrinolysis. So these clots are sticking around. We're using way too many clotting factors, and now we're going to have bleeding because now we don't have clots popping up where we want them to. That is going to affect our perfusion. We're going to be sending microclots all over the body. With our vasodilation and with these clots, we can lead to tissue hypoxia. We're not getting blood flow to our tissues. That is going to cause our mitochondria to eventually start to dysfunction. They're no longer going to take up even the oxygen that they are supplied. That's due to this hypoperfusion from the vasodilation. So this tissue hypoxia is then going to just progress our patient to being sicker and sicker and sicker. And that is when our cascade of events will trigger off and we can get into a shock state. What is our patient going to look like, our septic patient? We're going to see fever, hypotension. Fever's a normal infection symptom, right? So that makes sense. That is how we know an inflammatory response is taking place. Hypotension, we already talked about how we've got massive vasodilation happening. Tachypnea, we've got tissue hypoxia happening. Our respiratory system's going to kick in and try to compensate for that. So we're going to take more breaths per minute. Tachycardia, same. We have tissue hypoxia. Our body senses that and says, heart, we need more blood. Let's get some more cardiac output. Let's become tachycardic. Altered mental status, another sign of infection. Relative hypovolemia, which is what I was talking about earlier. We see that extreme vasodilation. It doesn't matter if that patient really had any blood loss or volume loss. They now have technically a relative hypovolemia. There's not enough volume to fill those vasodilated blood vessels. Okay, risk factors. We see this more. Infection is just going to affect those in advanced age, male gender, malnutrition, and any sort of comorbidities. Sepsis will hit these populations harder. Okay, diagnostic tools. So we already talked about when we're diagnosing SIRS, we're going to use this criteria. SOFA score is another thing that we can look at. This is looking at sequential organ failure. So we can assess how much oxygen is in the patient's blood. We look at PaO2 to look at that versus how much oxygen we're giving them. That's FiO2. If you've got a patient on the ventilator, they're receiving 100% FiO2 and their plasma oxygen content is still really quite low in the 50s to 60s, and you're giving them 100% oxygen, you know you've got a really significant problem. Our organs are not doing well. They're not receiving enough oxygen. Is your client on mechanical ventilation? That is part of this assessment. Platelet count, Glasgow Coma Scale, so how's their neuro assessment? Bilirubin tells us about their liver. MAP, how are we perfusing? And creatinine can tell us about if our kidneys are clearing our waste products. So we can see how all of this here is relating to multiple organ systems. If we're starting to retain bilirubin and creatinine, we know we've got liver, kidney issues happening. Lab analysis, the big one here is our cultures. We know that we need an infectious source. So we're going to look at blood cultures, respiratory cultures if we're suspecting a pneumonia, urine, etc. Oh, talk slower. You've got it. I can talk a little slower. I have so much to cover in this little webinar. So I can get myself to talk a little too fast. But if we don't make it through everything, that's okay. You're right. I'll slow down just a little bit. So blood cultures, something to remember with our cultures is we want to ensure that we are waiting to start initial antibiotics until after those cultures have been drawn. They can change what comes out with our cultures, how those cultures result. So we want to ensure that we are getting our cultures first, then starting antibiotics right after we draw those cultures. We don't need the cultures to result. We just want them to be drawn before we start antibiotics. Inflammatory markers. Lactic acid is a huge indicator of sepsis. Lactic acid is secreted in anaerobic metabolism. So when we start to, our tissues transition from aerobic metabolism, where they've got plenty of oxygen and they can kind of metabolize easily, and now they don't have enough oxygen, they switch into anaerobic metabolism. And that is there's a byproduct from that process, and that will be lactic acid secretion. So we can actually send a lactate off as a blood test and say, oh, okay, we are absolutely in some sort of tissue hypoxia. We're secreting lactate right now. So that is a huge tell. It is an acid, so this can lead to metabolic acidosis very, very quickly. Procalcitonin is another inflammatory marker that we can send in a blood test. It's secreted in response to inflammatory cytokines. C-reactive protein synthesized in the liver. It also rises in inflammation. So typically, if we're concerned about sepsis, septic shock, any sort of tissue hypoperfusion for a patient, we're going to send all three of these labs and see what they look like. Now, coagulation studies become very helpful if we're worried about that DIC, disseminated intravascular coagulation. If we're using up all of our clotting factors, our bleeding times are going to be prolonged. So we're going to see that in INR, PT, PTTT. D-dimer will also see elevated with DIC. CBC and CMP, this is where we're going to get that elevated white blood cell count. And we want to see over 10% in mature forms. That basically tells us that we're having a new active infection. That body's making new white blood cells, not ones that have been around for a while. Okay, so in the ICU, when we get these patients, we're going to care for them with bundles. These exist for a lot of different disease processes out there, but our sepsis management bundle is probably one of the most common. We have things we want to do at the 3-hour mark, things we want to do within 6 hours, and then things we're going to do over the next 24 hours. And this is because sepsis is so common that at this point, we've been able to develop these protocols that are pretty much nationally accepted. So let's take a look at what we're initially doing. I already mentioned it. One of the first things we're going to do when we suspect sepsis is get blood cultures. We have a suspicion that this infection has reached the bloodstream, and that's why we're seeing a systemic response. So let's get some blood cultures and then immediately start antibiotics. We want to get something started for this patient right off the bat. They might not be the most specific antibiotics or narrow spectrum antibiotics because we don't have these culture results back yet, but we can start some broad spectrum antibiotics, try to kill anything and everything until we get cultures back within a couple of days. Then we can start to further narrow that antibiotic. Let's take a look at their lactate. If their lactate's really elevated, they're acidotic, we might need to support that acid-base imbalance, and we'll probably give some fluid. That's what clears this lactate out really effectively. Fluid resuscitation is part of our 3-hour bundle for sepsis. This person is relatively hypovolemic. So again, they haven't experienced actual volume loss, but their body is kind of behaving as if it has because they're so vasodilated. So our guideline for fluid resuscitation for sepsis is 30 milliliters per kilogram, especially if they're hypotensive or if that lactate level is over 4. The hypotension is typically what triggers us to know, okay, this infection is now a sepsis situation. We're having that systemic vasodilation response. So then we'll trigger this fluid resuscitation. And we can give this fluid relatively quickly. We do want to look at our patient's heart, just heart function. If they are in any sort of heart failure, then we might give fluid a little bit slower to not increase the workload for that heart. Okay, so after that 3-hour bundle, we are going to go into our 6-hour bundle. By this time, we have fluid resuscitated this patient. We've given them the amount of volume that this criteria calls for. If we are still hypotensive, which we might be, we are going to start some vasopressors. That is going to help with that vasodilation. Fluid can help a lot because we are in that relative hypovolemia. Volume equals pressure. So we'll increase our volume and ideally our patient will have a good response to that and we won't need to start vasopressors, but not every time. They're still massively vasodilated. This goes for SIRS as well. They've got massive systemic inflammation. We can see that vasodilation. We might need to give a vasopressor to vasoconstrict those blood vessels. We want to watch that lactate. Typically, we draw lactate levels every 6 hours or so. That's how we can see what our interventions have done to our lactate number. And we will reevaluate the need for further fluid resuscitation. This is the guideline for what clients typically need, but they might need more. So if we find that they're still responding, we're seeing some increase in blood pressure when we give some fluid, we'll continue to give more fluids. Again, as long as their heart's doing okay and we're not seeing new pulmonary edema or anything like that. In the next 24 hours, as we continue to care for this client, we will add on a corticosteroid if needed. What do we know about corticosteroids that would be helpful in treating sepsis? They reduce inflammation. In our sepsis client, we have massive inflammation happening, as we've said. So corticosteroid can help suppress that inflammatory response. We want to do some source investigation. Where is this infection coming from? Avoid any sort of hyperglycemia. That does not help when we're trying to heal from an infection. It actually feeds an infection. Assess their antibiotic therapy. Have any of those cultures come back? Can we make a more narrow choice for their antibiotic? And for every single ICU patient, and I dare to say most clients in the hospital in general, we want to administer stress ulcer and DVT prophylaxis. This person is already struggling quite a bit. They are requiring a lot of medical support. The last thing we need is for them to also develop a stress ulcer. They are more acidotic. Their blood is more acidotic than it was prior to sepsis due to that lactic acidemia. So their risk for stress ulcer is higher. Same with DVT prophylaxis, especially if we're in DIC and we're worried about both bleeding and clotting. We can give a small amount of anticoagulant to help deter clots in those lower extremities. How do you administer stress ulcer prophylaxis? I'm looking at some of the questions as they come in. So this would be typically IV administration of something like Protonix, some sort of proton pump inhibitor to help with the acid content in the stomach, help reduce how much acid's in the stomach so that we can prevent an ulcer there. And avoiding hyperglycemia, we'll monitor our patient's monitor our patient's glucose. And if we notice that they are hyperglycemic, then we'll give insulin. In this time that they're acutely ill, even for clients who come in and they don't have any sort of baseline diabetes, this type of sick can cause them to have high blood sugars that they normally might not, especially if we're on something like a corticosteroid that is known to increase our blood sugars. So we will check their blood sugars and manage that with insulin. Once they're through this acute stage of sepsis and potentially septic shock, then we will not, we usually don't have to continue to give them insulin. That is in the acute phase. And that, again, is pretty, that applies probably to all units in the hospital. But I know in ICU, sometimes we're sending off blood sugars every hour to make sure that we're keeping this in a really tight control. Might even have them on an insulin drip if we're giving high dose steroids that can increase our blood sugar. We just really want to avoid high blood sugar in the setting of infection. So nursing management wise, what are we doing as the bedside ICU nurses? First of all, we'd like to prevent sepsis. A lot of our patients come into the emergency room and they're already in it, but we have patients that are in the hospital for a long period of time that are at risk for infection. And that infection, any of them can turn into sepsis. So we are focused on infection control, mainly hand washing. I know y'all have heard that before. And then risk identification, knowing what certain infections your patient might be at risk for more than others. Early recognition. So this does become a nursing responsibility. We're at the bedside the most often. SOFA scores and SIRS criteria can help us do that and recognize that our patient might be dealing with some systemic inflammation. Prevent complications. So we are responsible for, with those bundles, when we get orders to administer certain antibiotics, doing that in a timely manner, getting cultures in a timely manner, doing things rapidly. These are our nursing diagnoses for sepsis. We obviously can see risk for infection and risk for shock, decreased tissue perfusion, risk for bleeding with that DIC, etc. So next I want to go into MODS, multi-organ dysfunction syndrome. This is something that can absolutely be caused by sepsis, and that's why it's fitting to talk about in this lecture. All that MODS means is a dysfunction of 2 or more organ systems. That classifies multi-organ dysfunction. We can have primary MODS, which is when we have some sort of organ dysfunction, multi-organ dysfunction, coming from a well-defined insult or injury. So a good example of this is a patient comes in with stab wounds to their liver and their kidney. They now have liver and kidney dysfunction, and they now have multi-organ dysfunction. That would be primary MODS. We know exactly why those organs are dysfunctioning. Acute kidney injury is another example of that. Patient comes in with a bad UTI. It travels up their ureters to their kidneys. They now have an acute kidney injury that now they're not clearing volume as well, regulating acid-base balance as well, because their kidneys aren't functioning well. Well, that's going to lead to problems with fluid overload. And now maybe our heart has too much volume to push around and we go into a little bit of heart failure. Now we have multi-organ dysfunction syndrome. Now, secondary MODS is what we see the most in the ICU. And this is the result of severe systemic inflammation. Organs are damaged that were not a part of the initial injury. So a cause of that would be sepsis. When we have this massive systemic inflammation, that massive vasodilation and capillary permeability, now we have hypotension. We've got hemodynamic impacts as well as pulmonary impacts with that pulmonary edema that can come from increased capillary permeability. I mean, all of our organs can be affected by by sepsis, leading us to MODS. When we now are in MODS and a lot of organs, or even just two, are now in some sort of dysfunction, it kicks off more hypermetabolic and inflammatory responses. So even though it was an inflammatory response that got us to MODS, the body's going to try to treat that MODS with another inflammatory response. So it's kind of a bad feedback loop. We are releasing even more inflammatory mediators. We're going to make our vasodilation and capillary permeability even worse. So MODS is something we want to recognize very, very early on to try to shut this process down. What does this look like? It depends on what organs we're referring to that are in dysfunction. If we're concerned about our pulmonary system being affected by MODS, then we might see ARDS. ARDS stands for acute respiratory distress syndrome, and it is characterized by massive pulmonary edema. We can see this ARDS response really anytime somebody goes into sepsis or septic shock. We have that vasodilation and capillary permeability, and that takes place at the alveolar level too. We're going to have leaky alveolar capillary membranes, and that's going to lead to some fluid on the lungs. That will give us ARDS. Alveoli can start to collapse on that fluid. They're not able to ventilate well, and we're now in respiratory distress. Pulmonary hypertension, as we can retain some fluid in our vascular space in the pulmonary system, gets to be a higher pressure. GI, ascites, so fluid retention in the abdomen. Paralytic ileus. Liver, we can see jaundice from that retaining of bilirubin if our liver is dysfunctioning. Hepatomegaly, a swollen and gorged liver. Metabolic-wise, we'll have increased muscle wasting, hyperglycemia, and increased lactate. That's all relating to that sepsis that we already talked about. Renal, oliguria. If our kidneys are not functioning well, they're not going to make great urine. So we'll have decreased urine output, and our labs will show increased creatinine and BUN. We're not clearing our waste products. Creatinine and urea are waste products that we're not clearing if we're in kidney dysfunction. CV, our heart, if it's really healthy and responsive, it can be hyperdynamic. It can try to kick in and try to perfuse our tissues so we can have increased heart rate and increased contractility. Or if that heart's starting to fail, we can have a hypodynamic heart. Neuro-wise, lethargy and coma. Our patient is going to be tired and they are probably acidotic, and that can lead to these comatose symptoms. Heme-wise, we already talked about this. Our client is going to be prone to coagulopathies like DIC, disseminated intravascular coagulation, clotting and bleeding happening at the same time. So how are we going to handle MODS? Maybe your client came in originally, they were in sepsis, they developed septic shock. Now multiple organ systems are involved and things just got really complicated. So how are we going to handle this? First, we obviously want to treat the underlying source of inflammation. That may require surgical intervention. I think about, I think I used it as an example already, but necrotizing fasciitis, which is a horrible, horrible skin infection that can interact with the bloodstream. At some point, we have to get that out. That tissue that has that type of infection needs to be removed, or else we are going to have a systemic infection for a very long time. Priority interventions are still fluid resuscitation and hemodynamic support. Think about your ABCs here. We are typically seeing this massive vasodilation response, and we can help overcome that with fluid as well as hemodynamic support, where we're going to actually give our patients some vasopressors or inotropic support, which would be increasing their heart contractility. I see a question here. I'll just answer it really quick. Low BUN or creatinine indicate. Low BUN and creatinine aren't too much of a concern usually. We have a normal range for BUN and creatinine, but if we're lower than that, then we're not usually too concerned, because that means our kidneys are doing a good job of clearing out those wastes. It's when they're increased that we're really concerned that our kidneys are not filtering our blood well. Okay. So yes, priority interventions keep our hemodynamics stable. We're also going to look, I don't think I put it here, but we're going to look at our respiratory status. Are we in ARDS? Are we in this respiratory distress from massive pulmonary edema? If so, that patient's going to need positive pressure ventilation. What that means is either BiPAP or CPAP in a non-invasive form, or invasive positive pressure ventilation, where we intubate them and put them on a ventilator. When you have really significant pulmonary edema and your alveoli are filled with fluid, gas exchange can't occur across that fluid. We need to push that fluid out of the way. And applying nasal cannula oxygen or even a simple face mask or a non-rebreather is not enough pressure going into the lungs to actually cause that fluid to shift out of the way. That oxygen really won't make too much of a difference. We need positive pressure. And that, again, is where we use BiPAP or CPAP for non-invasive, or we use or we intubate the patient and have them on the ventilator to be able to push that fluid out of the way and open their airways. So we need to assess our patient, see if they are in need of that. That will make a big difference with managing their tissue hypoxia. We also, during this time, want to support their nutrition. So this might mean placing a feeding tube, especially if they are on the ventilator. We won't have them eating, obviously. So we'll place a orogastric tube or a nasogastric tube so that we can support their nutrition and allow them to heal. We want to do that relatively quickly. When our client comes in and they're in the ICU and they're really, really sick, their blood pressure is not looking great, they're on a lot of medications, we can quickly think, oh, well, feeding them is our last priority. And I think the whole nation is really working towards fixing our mindset about that. Even if we are having hemodynamic problems, we can usually still feed this patient. So we need to prioritize that early on to help assist with their healing. Additional nursing management for MODS. We want to prevent this. So if we start to see it, let's say your patient's got a Foley catheter, you start to notice that their urine output starts to dwindle, maybe advocate to send off some kidney labs earlier. See if we can prevent an acute kidney injury from sepsis before it happens. Just to assessing every single system of our client to make sure that there's not dysfunction happening that we're missing. Infection control goes for every single client. Reduce oxygen demand. This comes down to analgesics like pain medicine and sedatives if needed. This person is experiencing massive tissue hypoxia. We want to reduce the amount of demand that they're experiencing, especially if they're on that ventilator. We want to make sure they're on sedating and pain control medications. It will really help that ventilator do a lot more work for that patient if we can reduce their oxygen demand, really settle them down. Nursing diagnoses for MODS, multi-organ dysfunction syndrome, here's just a few. Decreased cardiac output, impaired gas exchange, impaired nutrition, risk for infection. Similar to sepsis. So I'm now going to bridge us into the rest of the shock states. I wanted to start with sepsis because one can occur without truly being septic shock. And it is the main cause for MODS, but really any shock state can technically get us to multi-organ dysfunction syndrome. Because as soon as we're not perfusing multiple organs to the point that they start to dysfunction, we're now in MODS. And any shock state can get us there. It is most commonly septic shock. So I wanted to kind of include it with that sepsis state of mind, but just know that any shock state leads to that hypoperfusion, and we can quickly get to organ dysfunction. So let's talk through some shock basics. I think I've got enough time to get through all of this, which is exciting. I didn't think I would. So our shock basics are going to refer to processes that happen no matter what type of shock we're in. These are universal to our shock states. So at some point, what's happening is we're seeing cellular hypoxia and hypoperfusion that's going to lead to tissue death and organ dysfunction. And when that starts to happen, we're in shock. It's either caused by inadequate oxygen delivery, we're not getting enough oxygen to the tissues, or we have such an increase in oxygen consumption that our oxygen delivery just will never be able to keep up with it. We have 4 stages of shock. Again, no matter what stage, no matter what type of shock we're in. Initial, compensatory, progressive, and refractory. So initially, what's happening that causes this cascade of events to start is tissue hypoperfusion. That has to occur. We have some area of tissue not getting enough oxygen. Now, the body is going to compensate for that, and that's going to kick us into our compensatory stage. We have an immediate response to that lack of perfusion, and the body's going to try to make up for it. So we're going to see if our kidneys, for instance, aren't getting enough blood flow, our body's going to realize that and say, heart, we need to send more blood to the kidneys. So increase your heart rate. And in addition to that, don't just increase how many times per minute you're beating, also squeeze harder, get more blood out every single contraction to really optimize our cardiac output. We're also going to prioritize blood flow to vital organs with vasoconstriction and vascular resistance. They're going to clamp down our blood vessels to send blood flow where we want it. Antidiuresis. We know that volume equals pressure. So if we're in a hypoperfusion state, we don't have enough blood flow going to an area, we're going to hold on to blood volume, to fluid, to increase our blood pressure. Glucocorticoid release to increase our glucose level, give us more energy to fight whatever's going on and causing this tissue hypoperfusion. Epinephrine and norepinephrine, our fight or flight hormones, are going to be released. This will cause further shunting of blood to our vital organs, increase that heart rate, increase contractility, and increase our vasoconstriction so that we can increase blood pressure. So this is good. Our body is going. It's fighting to restore perfusion to these tissues. The problem is the body can't keep up with this for super long. And that's when our progressive stage of shock kicks in. These compensatory mechanisms are going to fail to meet the demands, and the body ultimately is just exhausted. The heart can only beat at 150 times per minute and with a really hard, intense squeeze for so long before that heart starts to give out. Now we're not going to be meeting these demands. That's when that aerobic metabolism at the tissue level is going to transition to anaerobic. We now have that lactic acid being secreted as a byproduct. That's going to lead to lactic acidemia. Vasodilation and capillary permeability are continuing to occur due to that hypoxia. Those are, if you leave this webinar with anything, I want you to remember that those are the main symptoms that make a client critically ill when we are fighting an inflammatory response, is that vasodilation and capillary permeability. Those are huge in understanding why our patients actually get so sick from an inflammatory response. And then finally, our mitochondria rupture and cells can no longer use oxygen even when we're supplying it. As this continues, if this client gets no interventions, we will enter a refractory state of shock. Whenever you hear the term refractory, I want you to think not responsive to treatment. Sometimes we will use the term refractory hypoxemia. That is used a lot of times with pulmonary edema. When we've got those fluid on those lungs, and I said, you can put as much nasal cannula oxygen on that client as you want, but there's fluid in the way between the air and the bloodstream. It's that oxygen, that air can be as oxygenated as you want it to be. It's not going to make it into that bloodstream if we've got significant pulmonary edema. That's refractory hypoxemia. It's not responsive to that treatment. So the same thing happens here. At some point, these tissues are too far gone. MODS has occurred, significant MODS, where multiple organs are involved, and we are going to lead to organ failure and death. We can only go with hypoperfusion for so long before tissue just starts to die. So let's now talk about the different types of shock. We've got a few of them, 5 of them. So first of all, we have hypovolemic. Hypovolemic is in the name. We don't have enough volume. We have intravascular volume loss. This means, I think it's important to emphasize that it's intravascular volume loss, meaning we can have the patient might not have lost a significant amount of volume through bleeding or urine output, let's say, but that volume isn't in the vessel. Maybe it has third spaced into the tissues. The patient is very, very edematous, and that volume is sitting in the tissues. It's not in the blood vessel. So we can see hypovolemic shock even when the client actually looks fluid overloaded. Cardiogenic, we're seeing cardiac output reduction from an intracardiac source. Something happened inside the heart. Myocardial infarction, a valve went down, something happened in the heart, and now we cannot have a sufficient cardiac output. Finally, our third category of shock, which contains our last 3 types of shock, is distributive. When you hear distributive, I want you to think massive peripheral vasodilation. Vasodilation does not occur in these other 2 types of shock, but it does in these. And we know that it's happening in septic shock because of that inflammatory response. It happens in anaphylactic shock as well, kind of the same principle, an inflammatory response to an allergen trigger, and neurogenic, which we'll get to as well. We lose our sympathetic tone. So we are going to have massive vasodilation as the parasympathetic system, our rest system, is in control. So those are our types of shock. We're going to break each of them down. So I'll kind of go quickly through the rest of this. Common characteristics for all types, or for most types, is tachycardia, tachypnea, oliguria, lactic acidemia. Tachycardia, I'll go ahead and tell you, is not part of neurogenic shock. That's the only type of shock that tachycardia is not going to be present in. And hypotension, we have a MAP under 60. This can be an early or a late sign of shock, but we are seeing that hypoperfusion in shock, typically from hypotension. Diagnostic tools, we're going to look at our client, and labs are very helpful. What does their ABG look like? Lactic acid, CBC. We're looking at all those labs to see if we can paint a picture. Goal of management is obviously, we want to restore tissue perfusion, improve our cardiac output, oxygenation, get our hemoglobin up if we're in hypovolemic shock from a hemorrhage. And any further management is going to be very specific to the type of shock that they're in. Can I ask, what does it mean if MAP is high? That just means you're hypertensive. So instead of having a low blood pressure, you have a really high blood pressure. And there's lots of different things that can cause that. In fact, in shock, we might see a high MAP first, and then as things start to fail, our MAP can really drop. Calculating a MAP is a certain equation, but it stands for mean arterial pressure. So it's something that we use in the ICU very, very often. We don't typically go by systolic and diastolic pressure. We really care about what their mean arterial pressure is. And we want it to be over 65 typically for really good organ perfusion. We know we're in a severe shock state if it's under 60. But the calculation, I don't know offhand, but there is a calculation there. And typically when you take a blood pressure in practice, it will give you the MAP in addition to your systolic and diastolic pressure. Okay, let's get started here with hypovolemic shock. I've got about 10 minutes. So we're going to kind of race through these. I gave a little bit of a blurb on each of these So we're just going to kind of close out the picture for each of them. So hypovolemic shock, we have reduced volume, intravascular volume loss. This is going to lead to a reduced cardiac output. The equation for cardiac output is stroke volume times heart rate. So if we don't have enough blood going to the heart, returning to the heart to be pumped out to the body, then our stroke volume is going to be reduced, and naturally we'll see a reduced cardiac output. If we don't have enough volume in the vascular space, we have hypotension, and that's going to lead to tissue hypoperfusion. We're not going to be sending enough blood flow out to the tissues. Now, the primary compensation response for this is increased vascular resistance. The body is going to sense that we have a reduced blood pressure, and we have a reduced amount of volume in the blood vessels. And it's going to say, okay, let's vasoconstrict to make what we do have in the blood vessels more effective. Which if we have any sort of heart dysfunction happening with hypovolemic shock, that can become complicated. We've now just increased afterload for our heart in an effort to help in this hypovolemic shock. Now, what type of people are getting hypovolemic shock? The main type is hemorrhagic, a massive GI bleed. Maybe there's some sort of vasculature damage, like an aortic aneurysm would be a reason, or an aneurysm rupture. Surgical error can quickly lead to hemorrhagic or hypovolemic shock. Non-hemorrhagic can just be any other type of GI loss. So vomiting and diarrhea and G-tube suction. Diuresis, we can over-diurese our clients and send them into hypovolemic shock or some form of hypovolemia. Burns is huge. We have massive endothelial damage happening in burns. That leads to huge third spacing of fluid, where we're losing volume in the vessel space, even though it's sitting somewhere else. What does this patient look like? We have our standard shock symptoms in addition to more significant orthostatic hypotension. Whenever our blood pressure is low due to a lack of volume, when we have those changes in position where a patient goes from laying down to standing up, we're going to see the effect of that drop in blood pressure a lot more significantly when we don't have as much volume to help overcome that change in gravity. Flattened jugular veins, so they're not distended because we don't have a lot of volume in the blood vessels, right? And narrow pulse pressure. Our stroke volume is reduced, so our systolic blood pressure is going to be reduced. But in diastole, we're trying to vasoconstrict to compensate for this lack of volume. So we'll see an increased diastolic pressure, reduced systolic blood pressure, and increased diastolic blood pressure. Now our pulse pressure, which is just the difference between systolic and diastolic blood pressure, they're now much closer together. Diagnosis-wise, we're going to see these shock symptoms and know and have some source for volume loss for our patient. That will put them in the hypovolemic shock category. And their lab assessments will show that as well. Elevated lactic acid specifically. We might not see elevated white blood cell count or some of these other things that are more indicative of inflammation and sepsis. We're going to see, but we will still see this lactic acid because we have hypoperfusion and our tissues are in anaerobic metabolism. We know that lactic acid is the byproduct of that. Medical management, we're going to assess for that cause and fix it. If your patient's massively hemorrhaging, they probably need to go to surgery and have something plugged, something taken care of there. In the meantime, we will offer fluid resuscitation and blood transfusions if it's a hemorrhagic problem, and then blood pressure support. So we can give our patients some assistant with some vasopressor and inotropic support as we're getting their intravascular volume restored. Really quickly, fluid resuscitation and shock. This goes for septic shock as well. When anytime in any shock state that we're giving fluid resuscitation, hypovolemic being our most common one, we need to think about what type of fluids we're giving our patients. We don't just give everyone normal saline. We need to consider colloid versus crystalloid. I always think of thick versus thin. Colloid would be like a blood or an albumin, so it's thicker. Crystalloid would be like a normal saline or an LR or a lactated Ringer's. Albumin is protein. we can infuse protein into the bloodstream to cause an osmotic difference in the blood vessel. So if we have that third spacing problem, let's say with our burns patient, and we know that there's fluid in their body, it's just not in the blood vessel anymore, and we want to pull it from the tissues back into the blood vessel, we can give albumin a large amount of protein to help pull pull fluid into the blood vessel. Consider your differences between hypertonic, isotonic, and hypotonic. We're typically giving isotonic volume resuscitation. Hemorrhagic will require both colloid and crystalloid replacement. Non-hemorrhagic will require isotonic, sometimes hypotonic crystalloid replacement. That blood can be hemoconcentrated, so we might not want to give colloids. With hypovolemic shock, we're typically giving 2 to 4 liters at a minimum, in addition to any blood that was lost to reverse the shock state. Okay, I've got 5 minutes left. Whoo, let's see. I will, let's see, briefly talk about cardiogenic shock and then I'll stop. So cardiogenic shock, we already talked about. Severely reduced cardiac output from an intracardiac source. Etiologic factors for that, we'd see cardiomyopathies, arrhythmias, mechanical problems like an aortic or mitral valve dysfunction. That could also be a papillary muscle rupture. So papillary muscles are responsible for holding on to the valves. And when we have a myocardial infarction and we start to have some muscle death, that muscle can rupture because it's dying. And now that valve is no longer very effective. Valve problems are huge when it comes to cardiogenic shock. They really sustain and allow for our cardiac output. The fact that the doors are open when they're supposed to be open and closed when they're supposed to be closed to allow for blood to flow through the heart is very, very important. Cardiac tamponade is another reason for cardiogenic shock. What I want us to think about really quickly with cardiogenic shock is when our body compensates for cardiogenic shock, we are going to see increased vascular resistance, right? Our cardiac output's reduced. The body senses we're not getting a lot of blood flow out of our heart. Let's increase our vasoconstriction. Let's vasoconstrict our blood vessels to try to optimize our blood pressure. Let's also increase our heart rate. Like, heart, what are you doing? Why aren't you sending us some more blood? And those both in turn are going to overload our heart. We just increased our afterload by the vasoconstriction and increased the workload in general by increasing the heart rate. So our compensatory mechanisms in cardiogenic shock are particularly harmful for our patient. So if we realize that somebody's in cardiogenic shock, we really need to intervene because this is what their body is trying to do, and it's only going to make matters worse. I feel like our body most of the time does an excellent job for compensating for dysfunction in other organs, but cardiogenic shock is a classic example of where that compensation is the worst thing that could happen to that patient. Assessment-wise, we'll see some chest pain, narrow pulse pressure. Again, we've got reduced systolic because our heart is struggling to form a cardiac output, but we have vasoconstriction, which will increase our diastolic. Now we have a narrow pulse pressure. Profound hypotension. Our heart is not pumping blood out to the tissues effectively. Decreased heart sounds, crackles from a backup of blood flow into the pulmonary system, and jugular venous distension from when our right side is not having good forward flow. Then we'll have a backup of blood flow to the venous system, and that will look like JVD. Medical management, vasopressor and inotropic medication use. Vasopressor seems counterintuitive. We already have this vascular resistance, but sometimes our hemodynamics won't allow for us not to have vasopressor. Ideally, we will try inotropic medication use first, see if we can fix our problem by increasing cardiac output, and only use vasopressors if we need to. Fluids, we can give fluid if our patient's not overloaded, but if we've got signs of these crackles and jugular venous distension, meaning our heart's already not doing a great job of moving what volume it does have through, then we might actually give some diuretics to reduce the workload on that heart. Surgical intervention is dependent on the cause. If we have a valve problem over here causing this shock, we need to fix it. In the meantime, we can put this patient on a device like Impella, balloon pump, or ECMO, which I won't dive into. but that a lot of times if we're in cardiogenic shock, our patient um, does need some support. Okay. Sorry, guys. I know I didn't make it through every single type, but we touched on most of them here. Um, and we spent a lot of time on sepsis, which is a form of a form of distributive shock, which is what our others were as well. So I'll kick it over to you, Annie.
Yo, Rebecca, that was wonderful. It's amazing to me how I learn something new every single time I watch you guys do these lectures. And I've been a nurse for a while at this point, guys. I know we had some questions on there that were just like, this was awesome. I mean, Rebecca is a great teacher. We have the best on here, but it is a lot of information to cover. The really great news about it is that, as we already talked about at the beginning, all of nursing school right now is totally free, and you can sign up at archerreview.com. And you can also use this link for private tutoring if you feel like you need a little bit more one-on-one because these topics are really heavy. But if you want to hear Rebecca talk more, see her cute face as she gives more lectures, and do practice questions that she helped write for this topic, you can go ahead and sign up for Archer Review for Nursing School. Joanne, I see your question about getting a copy of the PowerPoint. This exact PowerPoint's not available, but these are the exact slides that Rebecca lectures on in her ICU course when she talks about these subjects, and those notes are downloadable. So if you go to archerreview.com and you sign up for nursing school that's free right now, you can get access to all the cheat sheets she created and the PowerPoints there for this, and you can watch her talk a little bit more. So I know we didn't make it through every single thing entirely because it's so much information. I mean, it's amazing what she's able to cover in an hour. So if you want any more help on this, I would really recommend you sign up for Archer Review for Nursing School now. It's just going to be your best way to get more information on these subjects if you're struggling. Karen, if you're asking where the recording's going to be available for you, that is going to be on Archer Review's website. I can go ahead and I'll drop that link again for you guys in case you want to watch this back, so that you have that. I just put that in the chat as well. Thank you so much, Rebecca. And then once again, just with this private tutoring, we do offer more one-on-one stuff. I know this is with a big group where your questions maybe take a little bit longer to get answered. If there's something that you know is hard for you in nursing school and you want to work with one of our specialists, I mean, Rebecca's the smartest person I know with ICU stuff. She is a whiz with ICU stuff. Minored and majored in geriatrics. Brandon is the math guy who's great at dose calc. So you can go ahead and use this QR code to sign up for one-on-one tutoring sessions if you just feel like you want a little bit more help. Thank you guys for joining. That is where we'll end today. I'll let you guys leave. Feel free to reach out to our support email if you have any specific questions, but we were happy to have you here. Thanks, guys.